Good morning, everyone, and welcome to day 2 of Wish. I trust you're all finding it valuable. I personally am finding it inspiring to see some of the extraordinary work going on in healthcare, in innovation, how the two are coming together in different parts of the world, from the nudge psychologists, if I can call them that, teaching us about how to frame healthcare messages, to everything that you can see down in the gallery, the innovation showcases, things like augmented reality being used to help direct surgeons in their operations, to a really simple invention, simple but important and effective, on how you can precisely label syringes of drugs for use on the tiniest patients, babies and young children. So if you haven't yet been down to the gallery to see the innovation showcases, then I urge you to do so, because there are some really fascinating ones there. Now, one of the topics that's a focus of attention at this Wish is investing in health. You might already have seen the report on that subject. For obvious reasons, there's broad understanding of why investing in health is a good thing. But there's much less awareness on the exact scale of the return, the economic return on that investment, not only to the individual, but to our economies and the workforces of our countries. In that context, I'm delighted to welcome our next keynote speaker. He's one of the most influential economists of our time. He served as the chief economist of the World Bank, as director of the White House Economic Council, as US Treasury Secretary, and he also recently chaired the Commission on Global Health. Please welcome the Harvard professor and emeritus president of the university, Dr. Larry Summers.
Thank you very much. Your Highness, Your Royal Highness, Your Excellencies, delegates, I'm delighted to be here at this important summit. I want initially, on behalf of all of those who have come from abroad, to thank Qatar for its generous support and inspiring leadership in the global health effort. At a challenging time in the geopolitical and geoeconomic environment, this stands out as a bright spot. You may be asking, and indeed I sometimes ask myself, why is an economist like me, whose day job is about monetary and fiscal policy, giving the keynote address at the World Innovation Summit for Health? It's a fair question. I've always believed that economics is a moral science because it is so centrally involved with choices that directly affect human well-being. And cancer at age 30 reinforced for me that no choices so centrally affect human well-being as those involved with health. Economics has been classically defined as the study of the allocation of scarce resources among competing ends. Few, if any, resource allocation choices are as consequential as those involved with health care. I am here today because I have become convinced that even as we fight for increases in global health aid, there is a need for a major reallocation of the global aid for health effort away from financing, service delivery, and even system development in individual countries, and towards global priorities. And that's what I want to argue this morning. First, some background as to how I got into developing an interest in all of this. I had the privilege of serving as the chief economist of the World Bank in the early 1980s. One responsibility of the chief economist is to choose the topic for the bank's annual flagship publication, the World Development Report. I chose global health as the focus of the 1993 report because I wanted to illustrate, in an era when economists were focused on austerity and pro-market reform, that economic analysis could be harnessed to make the case for social investment. To the best of my knowledge, Investing in Health was the first major health report to be targeted at finance ministers rather than health ministers. It showed that well-chosen health expenditures are not a drain on the economy, very much the opposite. They are an investment in economic prosperity as well as individual well-being. Our report made the case that in countries with constrained resources, allocating resources towards cost-effective interventions for high-burden diseases offered a rapid and inexpensive pathway to improving people's lives. The report, produced by a team that Dean Jamieson did a splendid job of leading, was successful beyond our most optimistic expectations. Indeed, Bill Gates has credited it with spurring his interest in devoting much of his philanthropic energy to global health. To mark the 25th anniversary of the 1993 World Development Report, I was asked to chair the Commission on Investing in Health, an international group of leading economists and health experts, which published its report in The Lancet called Global Health 2035. Global Health 2035 laid out an ambitious framework to achieve what we called a grand convergence in global health by 2035. By grand convergence, we mean all countries improving their population health to a universally high status. When we look at the broad sweep of human history, as you can see illustrated in this graph, the norm was, for most of human history, and if we took this graph back to 1000 BC, it would look quite similar. Convergence was the norm. Population health everywhere clustered around a universally low status. Death rates for mothers and children were high. Almost everyone had an instance of losing a child in their family. While there was modest variation across space and time, mortality was high everywhere. Misery, as measured by contemporary standards, was the universal condition. But over the next 2 centuries, we saw the world diverge. Achievements in science, investments in public health, and economic progress brought vastly improved health conditions to citizens in the rich Western world, here in this slide, typified by Sweden. Those in the poorest countries, like China, were left behind. The result was a great divergence in global health. Countries diverged more and more until the middle of the 20th century. Then was a start towards global convergence. But this convergence is far from complete today. Only 1 in 150 children in the United States or Britain dies before the age of 5, versus a rate of 1 in 10 in the world's poorest countries. Global Health 2035 sought to demonstrate that we are now at a remarkable inflection point in human history. We have seen that countries like China, Chile, Costa Rica, and Cuba, the 4C countries as we labeled them, were able to rapidly converge on the mortality levels of the rich world by focused investments in scaling up medicines, vaccines, and other health tools. Our report found that with the right investments by donors and by low and middle income countries themselves, most crucially, nearly all of humanity could achieve a grand convergence in global health within just one generation. If you think about it, reconvergence in health, this time at a high level, this time with the kind of child mortality rates that prevailed in the United States when my children were born a generation ago, is literally a once in human history possibility. And it is here for the taking in the next generation. That is why this conference, that is why I believe there is no human endeavor more ultimately significant than the global health efforts of which you are all a part. This is not just a moral thing. This is not just an aspirational thing. This is a hard-headed financial reality. Our Global Health 2035 report showed that funds invested in achieving a grand convergence over the period between 2015 and 2035 would return benefits on average of $9 to $20 for each $1 invested. Such returns are extraordinary, and I can tell you on the basis of my day job, are not available in financial markets on any kind of predictable basis. Certainly not at a time when rich countries can borrow money in real terms at zero. And to take this further, when you compare the incremental return from different kinds of investments, assistance for education, transport, administration, whatever, the highest bang for the buck is very likely in the health sector. In 2012, a group of eminent economists, including some Nobel laureates, were asked to answer the question, if you could spend $75 billion to scale up existing interventions to improve the lives of the world's poorest people, what would you use? What would you prioritize? Here you can see their top 10 rankings. 8 out of 10 are healthcare sector interventions. Further examples can be found in a remarkable publication from the Center for Global Development called Millions Saved, a collection of case studies in which large-scale efforts to improve health in developing countries have succeeded and been highly effective. But this much you know, or you wouldn't be here, and you wouldn't be devoting your effort in the way you are. Today I want to offer a perhaps more provocative proposition by developing one particular theme that was just a minor key in Global Health 2035. I believe it is something of immense importance and urgency. My assertion is that we need a major rethink of the global health aid enterprise. Right now, 80% of donor support for health goes towards helping individual countries, and only 20% goes towards tackling global challenges, those that go beyond a single nation state. I have become convinced that this must change. There should be a substantial reallocation over time of international health assistance towards the global functions of health aid, those that tackle transnational challenges, providing global public goods like developing medicines and vaccines for the diseases of poverty, managing cross-border externalities like pandemic preparedness and antimicrobial resistance, and fostering global health leadership and stewardship like improving our priority setting processes. I should say that this is a judgment that I reach almost independent of the very important question of what the size of the global health envelope should be. Whatever its size, we will earn a higher return on our investments if we reallocate towards the global dimension. I want to make this argument at three levels. First, I'll suggest that for a variety of reasons, direct donor support towards countries' domestic efforts is inferior to domestic resource mobilization most of the time. Second, I'll make the case that anticipated economic growth in low and middle income countries will allow many of these countries to spend more and more of their own resources on their health sector, freeing them from aid dependence. And third, and most critically, I'll argue that there are enormously high returns on investment available from investment in global approaches. I'll end by providing a suggested time frame for the reallocation of global aid, reallocation of aid to global functions. As an economist, when I dispassionately compare a country's own support for health sector improvement with external support, I see a number of factors that can inhibit the impact of aid. Most important and most often ignored is the phenomenon of fungibility. I dare say my friend Julio Frank, who has recently become a university president, is seeing what I saw as a university president every day. An example from that experience makes my point. A donor would give us a professorship in, say, mathematics. Did that gift translate into increased education and research in mathematics? Perhaps to some extent, but surely knowing of the new professorship for the mathematics department, we reallocated our existing budget from mathematics to other fields. And even if we didn't reallocate any budget, when we allocated budget for new initiatives, mathematics, by virtue of being the beneficiary of that gift, was less likely to be the beneficiary of our incremental support. The result of the donor's gift was not primarily more mathematics research, it was more budget for the university overall. In the same way, studies have repeatedly demonstrated that foreign aid apparently earmarked for health or education, or for that matter, anything else, translates much less than dollar for dollar, in most cases, into extra domestic spending. There's also the question of sustainability. What happens when the aid inflows stop? Should they be permanent commitments? As the old adage goes, give someone a fish and they will eat for one day. Teach them to fish and they will eat forever. These issues were brought home to me with great power when I visited Côte d'Ivoire as we were working on the World Bank's health report that I referred to earlier. I was taken on a tour of a gleaming new clinic financed from foreign aid. When I remarked to the health minister the next day on how impressive the health care in that clinic was by the standard of health care in Africa, he nodded his head, he agreed, but he frowned. And I looked puzzled, and he noted that half the skilled doctor managers in his country had been hired away from his ministry by those who financed that clinic, and were now working in that clinic to the benefit of its patients, but to the great detriment of the vast majority of the citizens of his country, because only a tiny percentage of the population was being served by its facilities. Finally, inflows of foreign currency into a country, let's call it country X, can have a negative impact on its economy. Foreign aid inflows lead country X's currency to appreciate, to rise in value compared to other countries, other nations' currencies. That stronger exchange rate means that countries' exports becomes more expensive for other countries to buy, and imports from abroad become more threatening to local industry, thereby impeding economic development. This is not merely economic theory. Indeed, effects of this kind of foreign exchange flowing in are usually regarded by economists as a major reason why countries that are blessed with natural resources often, nonetheless, despite their easy access to foreign exchange, struggle to develop. To be sure, there are some countries facing highly straitened circumstances, like fragile or post-conflict states, where there is certainly a role for direct country-specific health aid. In this situation, the national government is unable to fulfill its domestic responsibilities, and the international community must step in. But on current trends, the number of such countries is diminishing, and in 2 decades, there will probably be only 24 or so of these countries, comprising less than 10% of the world's population. Which brings me to the second consideration I want to adduce: the remarkable dividend that will come from the anticipated economic growth of low and middle income countries. We calculated in Global Health 2035, and probably the calculation would be slightly less optimistic today, that while grand convergence will require about $70 billion per year in incremental investments in service delivery, and that is surely a significant amount. That $70 billion per year represents, hear me, less than 1% of the GDP, of the extra GDP that will be made available in developing countries as a consequence of economic growth over the next 20 years. If countries can devote 1% of their extra income to health investments and invest wisely, the possibility is there to avert 10 million deaths each year from 2035 onwards. This surely represents the greatest single opportunity available on the planet to improve human welfare. If local resources are sufficient to meet national challenges in most countries, and if substantial extra resources are becoming available, it suggests that one should look at global investments in healthcare. There's a classic economic principle here. It's called the free rider problem. If a country invests in better health clinics, its citizens capture all the benefits of the investment. If it invests in pandemic preparation or vaccine research or development of new service delivery techniques, the benefits flow around the world. So it stands to reason that without global cooperation, the world will underinvest in global goods. That's why global cooperation is so important. That's why summits like this one are so important. Here's a thought exercise that my Harvard colleague Barry Bloom once posed to me that made me see this point much more clearly than I had before. He asked me to take myself back to the 1953 polio epidemic in the United States. And he asked me to envision two strategic choices for a philanthropy. You can invest in what was then a compelling need for iron lungs, or you can invest in Sabin and Salk's efforts to develop a polio vaccine, a global public good. Fortunately, the March of Dimes chose the latter. They invested about $26 million in developing the vaccine. More than just in the United States, 160,000 polio deaths and 1.1 million cases of paralytic polio have been prevented. Treatment costs have generated a net saving of around $180 billion. And today, the world stands on the brink of eradicating polio altogether. It's hard to think of a better $26 million investment in human history. Let me give you just some other examples. The total cost of eradicating smallpox was around $300 million, but eradication has led to annual cost savings of over $2 billion. The international effort to develop an HIV vaccine is also likely to show very large returns. My colleagues, Dean Jamieson and Robert Hecht, estimated that every $1 invested would return, and they're certainly not being overconfident, given the breadth of this confidence interval, between $2 and $67, assuming a vaccine of 50% efficacy becomes available by 2030, and assuming $900 million in costs annually. Other game-changing innovations, like a single-dose malaria cure or inhaled oxytocin to treat life-threatening maternal bleeding, are likely to bring similar economic returns. But it is a mistake to suppose that it is only hard science research in laboratories that has high payoffs. So also are the returns to investing in population, policy, or implementation research. It was this kind of research conducted by the British statisticians Richard Dahl and Bradford Hill in the early 1950s that was the first and most convincing evidence to show that cigarettes cause cancer. The World Health Organization has set a target of reducing the global prevalence of smoking by 1/3 by 2025. If we can reach this target, we can avert 200 million tobacco-attributable deaths over the course of this century, both by helping current smokers to quit and by helping teenagers not to start. These are just a few examples of the benefits of global investments. In light of these considerations, I believe the world's allocation of health aid must change. It must evolve substantially and reasonably quickly to support the global public goods agenda. I think it would be a reasonable assumption to say that there is a need for roughly $11 billion annually of extremely high priority aid for global functions. If global health assistance remains constant, this will require that the proportion of donor financing directed at global functions increase from the current 20% to 50% by 2030. In other words, by 2030, half of all aid for health would be for global functions and half for country-specific functions. The lack of investment in the global goods agenda is, I would suggest, a huge and important gap. It could well be an international emergency. The next Ebola is probably just around the corner. The next flu pandemic, experts assert, could well be far deadlier than the 1918 epidemic that killed 50 million people in the era before mass international transit. Indeed, in some recent research, Dean Jamieson and I have sought to estimate the expected present value, that is, discounting back to the present, of the costs of future pandemics. We have found, and the estimates are surely speculative and imperfect, that cost is in the same range as the present value of the costs of global climate change, even though the pandemic attention issue gets only a tiny fraction as much attention. And I am very much aware that there are those like your keynote speaker yesterday who believe that AMR antimicrobial resistance may be an even larger issue. I have become convinced that the obesity issue is today where the tobacco issue was 50 years ago, with scientific awareness of an immense public health issue just beginning to be translated into policy action, and with huge needs for investment at the global level if the benefits of greater understanding are going to be realized. If history teaches anything, it is that new global issues will surely arise. So we need to drive a shift in how we spend our aid dollars. In our ordinary lives, we worry about allocating a portfolio to assure our safe and secure, more secure retirements. But here, when we talk about allocating a portfolio, we are talking about millions of lives being on the line. Tomorrow, here in Doha, with the kind support of the Qatar Foundation and the Bill and Melinda Gates Foundation, I will chair the kickoff meeting of a new year-long working group focused on international collective action for health. Our aim is to develop an analytically grounded agenda for global health investment that can command consensus across a broad community. A final thought. This is a moment of unusual uncertainty with respect to global cooperation. The citizens of many nations, mine included, are signaling their desire to turn inwards, to put their own countries first. Some of that is a legitimate reflection of the failure of domestic policies. Some of that is a reflection of the failure of those of us who have held leadership positions to educate publics on the broad benefits of international cooperation. But it makes it that much more incumbent on all of us to maximize the returns on every dollar of assistance that we provide. And I can tell you that as Secretary of Treasury years ago, I had far more time for those who did not just seek more resources for new priorities, but were willing to contemplate important reallocations so as to maximize the effectiveness of money spent. And so I believe in this world as it evolves, the case for focusing investment at the global level is ever more important. Tens of millions of lives are at stake. Thank you very much.